మనం PPT slide show.
Good morning, dear students. In the last class, I think we have dealt with the spaces of the head and neck region. Now today we'll discuss about the neck swellings. Neck swellings and various kinds of swellings are present in the neck. Depending on the location, they have been classified depending on their etiological factors or so that they are classified different kinds of classification. And let us try to go into the subject proper, wherein the neck. What is neck? We should know the anatomy of the neck, and then classification of various neck masses depending on different factors, and the main causes of neck masses. Okay? Neck mass is something, any swelling in the neck. Now the neck extends from the occipital region to the clavicles. That is the neck extension, and there are some landmarks for this neck. The landmarks are, first is the hyoid bone, which you can feel, and then you have the thyroid cartilage, then you have the cricoid cartilage, then the trachea down, and on either side you will see the muscles which are called the sternocleidomastoid muscle, one on each side. So these are the prominent landmarks which can be seen from outside, and so depending or according to the landmarks that we have, the neck is divided into different spaces. And before that, what is actually in the neck? What are the various structures that are present in the neck? We need to know. Now, as we go from outside, you have the skin, then the superficial fascia, then the platysma muscle, then the muscles, the strap muscles or sternocleidomastoid, the various muscles. Then you have the viscera, that is the larynx, trachea and the esophagus. Then you have the muscles, the various muscles which are anterior and posterior group of muscles, and you have the vertebral column, the vertebrae, the cervical vertebrae, and then you have the neuromuscular bundles, that is the nerves which come from the intracranium, and also the blood vessels, the arteries which go from the heart to the brain and to various parts of the neck. Those are the vascular, and the nerves which are coming from the cranial nerves and the sympathetic chain and the various nerve components. Then you have the lymphatic system, which is nothing but the reticuloendothelial system, which consists of the lymphatic channels and the lymph nodes. So these are the various structures that are present, and of course the vertebral bodies and the vertebrae proper. So these are the various structures that are present in the neck. In a cross section you can see all these, and that is the superficial layer, the platysma, the sternocleidomastoid muscle. Then you have the soft tissues, the thyroid gland, the parotid gland, and the submandibular, sublingual glands. Then you have the neurovascular bundle, that's the carotid sheath with its the common carotid and the jugular vein and the vagus nerve, and then you have the vertebra, and there is a space, prevertebral space, and the retropharyngeal space and the prevertebral space. Then you have the muscles which are supporting the spinal cord, the paraspinal muscles. So these are the various structures that are present in the neck, and so there can be a deformity or a kind of a various kinds of swellings arising from these various structures, and we'll try to go in to summarize the various this is once again the various layers of the neck, which divide them into small compartments, which has been dealt with in the neck last class. Then as I told you, it is divided for convenience sake into the triangles of neck. The triangles of the neck are, the neck is divided by the sternocleidomastoid into the anterior triangle, which is situated below the mandible, right up to the clavicle. Then you have the posterior triangle from the occiput to the clavicle again. So there are certain boundaries of the anterior triangle, and the anterior triangle is further divided into a submental region, a submandibular region, and a carotid region, carotid triangle, then a muscular triangle. Okay, so these are the boundaries: the mandible, lower border, and the sternocleidomastoid, and the midline, it is a midline line traveling along the midline of the neck. So these are the boundaries of the anterior triangle, which is further divided into the triangles, as I said, submental, submandibular, the carotid, and the muscular triangle. Then behind the sternocleidomastoid muscle, there is the posterior triangle, which is divided into two compartments, which is the occipital triangle from the occiput, and this is divided by a muscle called inferior belly of the omohyoid muscle. This divides the posterior triangle into an occipital triangle and a subclavian triangle. And then we go into the various, this is again diagrammatic representation of the submental, the submandibular, the carotid, and the muscular triangles of the which are components of the anterior triangle. Then you have the posterior triangle. This is the occipital, and this is the supraclavicular. So with this brief anatomy of the divisions of the neck, we go into the various contents that are present in the in these triangles. Now, the major triangles, as I said, the anterior triangle, the submental region, you have the submental lymph nodes. The submandibular region, you have the submandibular gland and the hypoglossal nerve, the mylohyoid muscle, the facial artery. These are the components which are present in the submandibular triangle. And when you come to the carotid triangle, there is the carotid sinus and carotid sheath, which consists of internal jugular vein and common carotid artery, vagus nerve, then external carotid artery, the hypoglossal nerve, ansa cervicalis, the spinal axillary, the deep cervical lymph nodes, the branches of the cervical plexus, the thyroid gland, larynx, pharynx. So these are the various structures that are present in the carotid triangle. Then if you go into the muscular triangle, you have the infrahyoid muscles, then you have the thyroid and the parathyroid. So these are the structures that are present in the anterior triangle. Then we go into the posterior triangle. The chief structure, the most important structures are the occipital triangle, transcervical artery, the external jugular vein, the spinal axillary nerve, which goes backwards, the branches of the cervical nerve plexus, and the brachial plexus. Then you go into the supraclavicular region, where you have the subclavian artery, the subclavian vein, and suprascapular artery, okay, and supraclavicular nerve, lymph nodes. Now these are the structures which are present in the supraclavicular triangle, which is part of the posterior triangle. Now usually these neck masses are defined as abnormal enlargements or swellings from the level of the base of skull to the clavicles. Clinically, neck masses can be divided into ones which are present in the midline, ones which are laterally situated. This is only for our convenience, and let us try to go into these various swellings that may be present in the anterior group or in the midline. So as I told you, the midline and the lateral, that's how they are there. The midline swellings are the dermoid cysts, thyroglossal cysts, thyroid lumps, thyroid swellings, the lymphadenitis, lymph node enlargements. These are the various structures that are present. And then in the submandibular triangle, you have the mostly the lymph nodes, along with the submandibular salivary gland. Then you have in the anterior triangle the lymph nodes again. Then you have the branchial cysts, which arises there, which are a little lateral. Thyroid masses, midline and lateral. The parotid gland, which is laterally situated. The paragangliomas are the carotid body tumors, glomus vagale, and these tumors which are laterally situated. And then the laryngocele, cystic hygromas, lymphangioma. These are the various abnormalities or masses which may be present in the anterior triangle. Then you go to the posterior triangle. The important structures are usually the reactive lymph nodes, neoplastic lymph nodes, and lipoma. And according to another classification, the more common causes are usually grouped under the congenital ones, which are present since birth. The lymphangiomas, the dermoid cysts, and the thyroglossal cysts. And then you have developmental, which are branchial cysts, laryngoceles, the pharyngeal pouch. And from the skin and subcutaneous tissue, you have these sebaceous cysts, skin elements, and subcutaneous tissue, it is the lipoma. Then if you go a little deeper, the thyroid swellings, midline, either goiters, which are nothing but enlargement of the thyroid gland, physiologically, or sometimes the neoplastic. The thyroid tumors or masses are divided into benign and malignant. Then you have the salivary gland tumors, pleomorphic adenomas and Dupuytren's tumor in relation to the submandibular triangle or the parotid glands. Then you have the infections in the oral cavity, which give rise to, because they drain into the lymph nodes of the neck, so the enlargement of the lymph nodes in the neck. Then you have the malignant lymph nodes, either they are primary or the lymphoreticular system malignancies like the lymphomas, Hodgkin's. So we'll try to go into certain important neck masses one by one, and most of these are usually given as short notes in the examination. Now, the first swelling that we need to understand is the dermoid cyst. This is situated in the submental region, and these dermoid cysts are the ones which are formed because of some of the ectodermal elements or which are overlapped or covered when there is a fusion. And so they usually contain the epidermoid appendages like the hair and the hair follicles, the sweat glands and the sebaceous glands. Usually they are present as smooth swellings which are present in the submental region, and then sometimes they may extend into the submandibular region. Usually painless unless they get infected. So if you examine the swellings, the swellings are smooth and superficial to the mylohyoid muscle. Mylohyoid muscle is the one which forms the floor of the which is called the diaphragm of the oral cavity. Then the diagnosis is usually made by ultrasound examination, ultrasound sonography, and the treatment is excision. So that is about the dermoid cysts that are occurring in the midline. Now another important mass that or swelling that is seen in the neck is the thyroglossal cyst. The thyroglossal cysts are nothing but the epithelial line cysts which are found anywhere in the tract between the foramen cecum, from where the thyroid gland originally is formed and descends down. So there is a tract all along which descends like that from the foramen cecum, which is situated between the anterior 2/3 of the tongue and posterior 1/3 of the tongue, and then it descends down and goes in front of the hyoid bone in relation to the hyoid body of the hyoid bone, and goes a little retro to the hyoid, and then comes down, and ultimately the tract extends to the level of the isthmus. So if there is any kind of a swelling which is occurring along with this thyroglossal tract, wherein the cyst consists of the epithelial remnants of the thyroglossal tract and composed of thick mucous material secreting columnar or squamous epithelium. Initially they form small cysts with a capsule, and they are in relation to the usually they are divided into suprahyoid and infrahyoid depending on their location. And these cysts are cystic in consistency, usually affecting the children, but it can occur later also. And there may be trans-elimination possible is seen when the contents of the fluid initially they are not infected, or if there is no hematoma or blood into these cysts. But once there is a infection, they become purulent and forms an abscess. And when this abscess ruptures, it forms a small sinus. So the complication of these thyroglossal cysts, if they are left to themselves, they have rich connection with the lymphatics that are present in the neck, and so there is always a possibility of these cysts getting infected sometime or other, and then form an abscess, rupture, and they form the fistula. They form a fistula, and keeps on draining the saliva. So these are the structures which are present in the, and these thyroglossal cyst moves up and down when the tongue is protruded and taken back. So that is the test which says that this is a thyroglossal cyst. Now the investigations are the ultrasound, CT scan for visualization of the location and the extent of the cyst, and of course the MRI. And if you see, this is how it looks like. This is the cyst that is seen in a CT scan. Now, apart from these radiological investigations to know the extent of the disease, in the differential diagnosis, we should also try to think of, because it is in the line of the descent of the thyroid gland, we should also consider a undescended thyroid gland. So in order to know that, you do an ultrasound and a thyroid scan to find out if it's a ectopic thyroid, which may be present right from the foramen cecum intraorally to the along the midline right up to the neck down. So the thyroid scan is the one which gives you the diagnosis whether it's a cyst or ectopic thyroid gland. And once you make a diagnosis of a thyroid gland cyst, the operation is called the cyst trunks operation, wherein you excise the entire cyst along with the tract right up to the foramen cecum, and it is closed. If you remove only the cyst, then there is always the recurrence is the problem, common complication of the thyroglossal cyst, and it forms thyroglossal fistula, which is much more nuisance. So excision along with the cyst and the entire tract right up to the base of the tongue is the surgery that is done. If you have, and in order to remove the component which is going behind the hyoid bone, you need to remove the body of the hyoid bone. So this surgical procedure is called the cyst trunks operation. Then, as I told you, the descent of the thyroid occurs from the foramen cecum along the midline in the neck, in front of the hyoid, and then down. Now, it may be arrested at any part of this tract, and so ectopic thyroids are the differential diagnosis, or also to be considered in the midline swellings. Then you come to another condition which is called ranula. Ranula is nothing but a mucus cyst. See, there is a mucus cyst, and this mucus is of the sublingual salivary gland. Now we know that parotid, the submandibular, sublingual, these are the major salivary glands that are there. So this is a cyst that is formed as a result of the obstruction to the sublingual gland, which is obstructed. And so this may be initially presenting only in the oral cavity just below the tongue, and this also restricts the movement of the tongue. And then sometimes as it grows, it may go deep and perforate the oral diaphragm, which is nothing but the mylohyoid muscle, and then present in the neck. This is called, there are two varieties that are described. One is the intraoral, the other one is the plunging ranula. Plunging ranula is nothing but the same this cyst, which is extending via the through the mylohyoid muscle and presenting in the submandibular or submental region of the neck. So that is the plunging ranula. Now this may produce complications like difficulty in swallowing, and when they get infected, that is another one, and they may give rise to abscess. So the treatment is excision and along the sublingual gland. If it's a plunging ranula, you have to approach this from the neck and remove the entire submandibular the sublingual gland along with this cyst. That is the treatment of choice. And sometimes if it's a small one, if it is only intraoral, you can do a procedure called marsupialization. Okay, you just have to make an incision and then invert the linings and then stitch. That is what is marsupialization. Now, another condition that we encounter, which is of inflammatory region, inflammatory condition, which is called Ludwig's angina. This Ludwig's angina, the site of infection is in the floor of the mouth underneath the the tongue. There is the entire floor of the tongue is elevated. There is difficulty in the movement of the tongue. Patient will present with difficulty, and since it's an infection, acute infection, the temperature increases. There is tenderness, there is pain and redness when you examine, and usually this is as a result of some kind of an infection which is present in the tooth. That's the commonest form of infection. There is an infected tooth. From there it has spread into the submental region, in the floor of the mouth, and it may extend down through the mylohyoid muscle, once again the diaphragm of the oral cavity, and then present in the neck. And the inflammatory process may spread in various directions. And the most important thing that we need to worry about is if the infection is spreading backwards and involving the epiglottis, and there is edema of this region, there will be a respiratory embarrassment, wherein sometimes you may have to do a tracheostomy. And the treatment is with antibiotics, but the treatment is surgical removal of the purulent material and drainage of the entire pus. So this is the treatment of the Ludwig's angina. And in the midline you have once again the thyroid isthmus. So any cysts in the isthmus or a kind of a small swelling may give rise to a midline swelling. And then you have the hyoid bone. The hyoid bone is there, and there is a space between the hyoid bone and the thyrohyoid membrane. There is a bursa, and there is inflammation of this bursa that also causes swelling in the midline of the neck, which is called subhyoid bursitis. And usually the treatment is the antibiotics. Now, enlarged submental lymph nodes. We saw in the submental region, you have these lymph nodes which are present, and so they get infected mostly because of the infections that are there in the teeth, in the oral cavity. There are ulcers there in the oral cavity. So the lymphatic drainage is into the submental region, and so the submental lymph nodes are the ones which get enlarged. These are the submental lymph nodes which usually drain the oral cavity and the floor of the mouth. And so when they get infected and inflamed and enlarged, they present as swellings in front of the neck, in the midline. Now, this is the acute cervical lymphadenitis. Then you have lymph nodes in the suprasternal space of Burns. Then just in the suprasternal notch, sometimes the arch of the aorta, there may be aneurysm which may present as a kind of a swelling which is present in the suprasternal region. That is the aneurysm of the aorta which you need to consider in the midline. So with these midline swellings, after discussing the important midline swellings and how we manage, then we go to the lateral swellings. The lateral swellings are usually the important masses or swellings are the pharyngeal pouch. I think last time we have discussed that the pharynx has got three muscles, the superior constrictor, the middle constrictor, and the inferior constrictor. The inferior constrictor muscle, or which is divided into the thyropharyngeus, and the other one is the cricopharyngeus muscle. And in between these thyropharyngeus and the cricopharyngeus muscle, there is a weak spot, which is in the posterior aspect. There is a weak spot through which the pharyngeal mucosa can herniate into this diverticulum, and the weak space that is present between the thyropharyngeus muscle and cricopharyngeus muscle is called Killian's dehiscence. Okay, the weakness is called the Killian's dehiscence, and the herniation of the mucosal pharynx is called pharyngeal pouch. Now, this pharyngeal pouch initially grows posteriorly, but since you have the vertebral column behind, it is pushed to one side. Usually, it will present onto the left side of the neck. So, this is how the presentation of the pharyngeal pouch, and usually it gives rise to the obstruction to the food, difficulty in swallowing, and swelling presenting in the neck. And when there is infection or obstruction of the opening of this pharyngeal pouch, the diverticulum into the laryngopharynx or the esophagus, the food gets accumulated there and then gives rise to infections and pain. Or sometimes when this pouch, which contains the food or the saliva or the material that we ingest, gets a part of it gets accumulated in the pouch, and then slowly it regurgitates back, and then these people usually have recurrent lung infections. There are pneumonias and lung infections. Okay. So this is these pharyngeal pouches initially start as a small diverticulum, and then slowly grow in size, become large globular diverticulum with the vertical mouth opening causing regurgitation, violent cough, dysphagia. These are and respiratory infections. So radiologically we have seen the various clinical features with which they present. And radiologically, you can take an X-ray of the barium swallow lateral view. Then you will see this is the pharynx, and that is the esophagus, like that, and that is the pouch, pharyngeal pouch. So the treatment of the pharyngeal pouch, depending on the extent of the pouch, if it's a small one, which is not very causing any significant clinical symptoms, you can just leave it. Otherwise, sometimes you may have to do surgical procedures. These surgical procedures are usually endoscopic procedures. They are very small, and the wall in between the esophagus and the diverticulum is cauterized and made wide, so that the pouch is in communication directly with the esophagus. That is one which can be done endoscopically. The pouch is big and the neck is small, then you have to do a approach from the cervical region and remove the entire pouch and suture the opening into the esophagus. So excision of the entire pouch is the treatment of choice in larger ones. Then the complications, as you know, the complications are the infection and mediastinitis, because esophagus posteriorly retropharyngeal space, and it may go into the mediastinum and produce mediastinitis, or there may be lung infections, if the sutures get infected and there is a pharyngeal fistula that may form, and sometimes the abscess in the neck. These are the complications of surgery. Then we come to another condition which is called laryngocele. Laryngocele is nothing but it's a dilatation of the laryngeal mucosa. It's also like the herniation of the laryngeal mucosa, usually present in the larynx. This is the epiglottis, and that's the laryngeal inlet, and these are the vocal cords. And so just above the vocal cords you have the false vocal cords. Now these, usually these are present in people, professionally trumpet players, the glass blowers, and people with chronic cough. During which time what happens is violent cough, there is some kind of a pressure that is exerted, and the mucosa slowly extends into this small space which is called the ventricle. And then it may be totally internal inside the larynx itself, producing a bulge in the false vocal cords. Okay, the space between the false vocal cords and the two vocal cords is the ventricle. So because of the pressure, air goes inside and forms a small pouch outgrowth which is called the laryngocele. And this laryngocele sometimes may extend as the pressure increases. As I told you, the professional blowers, the shahnai, the players, where they have to really blow with force. It may also, there is a membrane called the thyrohyoid membrane. The thyrohyoid membrane, which is pierced by the superior laryngeal nerve and the blood vessels which enter into the larynx. So that is a weak spot, and so the pressure may be transmitted and the mucosa may extend into the neck region, which is called the external laryngocele. This is called the internal laryngocele, which is totally restricted into the larynx inside, and there is a bulge in the endoscopically. You will see a bulge in the larynx, in the vestibule, and the external one is piercing the thyrohyoid membrane, where there is a weak spot, where the superior laryngeal nerve and the blood vessels enter into the larynx. That from that area it may protrude outside and then give rise to the external laryngocele. So this is what this is the diagrammatic representation. This is the ventricle. This is called the ventricle, which is the space between the true vocal cords and the false vocal cords. So this herniates if it is only restricted. This is the thyroid ala, thyroid cartilage, and so as long as it is internal to the thyroid cartilage, it is called internal laryngocele. And once it ruptures this, or it goes through this is the hyoid bone and this is the thyroid cartilage. So this is called the thyrohyoid membrane. So through which it goes into the neck, that is called external laryngocele. So if it is small and if it is not giving any problem, it can be left alone. But if it is causing respiratory obstruction, because internally as the size increases, it compresses the laryngeal inlet, and so you may have to do surgical procedure to excise this and the external ones. So this is the treatment of choice, and clinically usually it presents with a swelling in the neck which increases in size when you blow or when you cough, or when you perform a Valsalva maneuver, closing the nostril and the mouth. You are asked to swallow and blow. So that is Valsalva maneuver. So you will see that the size of the gland, the swelling increases. So that is diagnostic of a laryngocele And as I told you, the treatment, the radiologically, you can confirm this. As I told you, the internal laryngocele, where you marsupialize with the help of a laryngoscope, and if it is external laryngocele, the excision of the through the neck of the sac. Then we come to branchial cyst and sinus and a fistula. Cyst is nothing but a cavity, cystic fluid lined the cavity, and the sinus is a deep ulcer, and a fistula is a communication between one cavity to another cavity or one cavity to the exterior. Okay. Now, usually the branchial cysts are the congenital variety, and these are as a result of abnormal development of the branchial apparatus, which usually arise from the arches of the branchial arches. The branchial arches, the second arch, third, fourth, fifth arches. So the common types are the second branchial cleft cyst. These are situated in the junction between the anterior part of the sternocleidomastoid, and the branchial cyst is present at the junction between the upper third and the lower 2/3, and that's called the branchial cyst. And the branchial fistula, when this cyst gets infected and gives rise to ruptures, it gives rise to the fistula, the branchial fistula. And the second arch is the one which is commonly produces these branchial cysts. And third and first branchial cleft cysts are not very common, and the diagnosis is by radiological ultrasound, and the FNAC gives rise to these cholesterol crystals, and X-ray, contrast X-ray, which is called the fistulogram. You inject the dye into the fistula and then see the entire tract. The treatment is by surgical excision. The excision has to be right from the this sinus. If it is a sinus, the entire tract right up to the tonsil region intraorally. That is how it, and this is the one which goes in between the external and the internal carotid arteries, because it is the developmental wise, it develops from the second branchial cleft. Now, that is as far as the treatment of the branchial cyst and the fistula. So these present as cystic swellings in the anterior region of the sternocleidomastoid muscle, and usually in the second arch is the one, second cleft is the one which is more common. Third and first cleft cysts are not very common. Then the lymphangiomas, these are the congenital cystic lesions, which are because of the abnormal development or incomplete development of the lymphatic system. The lymphatic system is not developed properly, and so the fluid, the lymph, gets accumulated in the form of various the locules, the various cysts, and usually they present in a young age, in 2 years, and sometimes they may be present at birth also. Usually with a small swelling, it may not give rise to much obstructive symptoms, but as the cyst grows, it gives rise to some problems in the difficulty in swallowing, and as you know, it is compressing the neck, and sometimes it may obstruct or narrow the laryngeal inlet and gives rise to the stridor obstruction, laryngeal obstruction, in which case you may have to do a tracheostomy necessary, and then the treatment is by excision of the entire cyst. Sometimes, in order to facilitate, if it's a big swelling, you may have this sclerotherapy, wherein you inject sclerosing agents which form some kind of adhesions, and so the size of these cysts or the swelling comes down, then which is amenable for surgical excision. So this is how the lymphangiomas, which are otherwise called the cystic granulomas, cystic hygroma, which are present in the neck, lateral part of the neck. That is as far as the lymphatic and the cystic hygroma is concerned. Then we go to another kind of a tumor which is present in between the two forks of this is the common carotid artery, which divides into the external carotid artery and the internal carotid artery. The external carotid artery has got branches, the internal carotid artery doesn't have branches. So it is in the fork, the carotid fork, and these are usually arising from the chemoreceptor organs that are present at the bifurcation, which detect the oxygen levels and the carbon dioxide levels and secrete the hormones which increase the heart rate. So the catecholamines are. Then these tumors, when they grow, they present as swellings in the lateral part of the neck, usually present in the 4th or 5th decade, and the slowly grow in size. And so the clinical features are usually these are swellings which are present in the carotid triangle, which we described, and they are compressible because it's a vascular thing, and sometimes you may feel the bruit or thrill, the pulsations are felt, and so the mobility is from laterally they are mobile, but up and down they don't move, and if they are large they can give rise to symptoms like dysphagia, a change in the voice. Now sometimes when you press the carotid body, you may go into a kind of a syncope. So these are the tumors which are called the chemodectomas, which are present in the fork between the external and internal carotid arteries. And the diagnosis is usually made by a radiological diagnosis, CECT, contrast enhanced CT, and MRI with gadolinium, and MRI angiography to see the various blood vessels which feed the tumor. Usually the FNAC is avoided because it's a vascular, it can bleed. Treatment in the young age, surgical resection by trans-cervical approach. It has to be excised. And if the tumor is very vascular, it will be vascular, but in order to reduce the vascularity, you can do arterial embolization to decrease the bleeding during surgical procedures. And these are diagnosed, as I told you, by the radiological, and also the 24 hours urine BMA estimations and serum catecholamines assessment. So the treatment is excision. Then we come to the lymph nodes which are present, the entire neck, the midline, the lateral, and the posterior group of posterior triangles. And so the infections are usually chronic infections which are present, and the most common chronic infection that we have in our country is the tuberculosis. So these are usually painless to start with, the increase in size and evening rise in temperature, night sweats, and weight loss because the appetite is down. Then you have the various stages that are presented, are described, and these various stages are: initially there is inflammation of the lymph nodes, discrete nodes, and when the size increases they come together and the outer capsule of the lymph nodes get fused with the outer capsule of the adjacent lymph nodes, and so produce what is known as the periadenitis and give rise to the matting. Then and the central area gets necrosed, and so the caseous material is formed there, and this caseous, as it increases with the pressure, the fascia sometimes which is covering that may yield and then give rise to a subcutaneous swelling which is present as a cold abscess. This is called, it's a cholesterol abscess. There is abscess here, there is a small narrow neck region, and then it is widened again. So this abscess is not like the acute abscess. Temperature is increased and the pain, fever, such things are not present. That's why it is called a cold abscess. So the problem is somewhere deep inside, but it presents, the caseous material presents subcutaneously, and once it ruptures it gives rise to a sinus, that is, they communicating from this cavity into the outside, which is called a sinus. So the diagnosis is by the X-ray and the Mantoux test, and then sometimes you may take a lymph node for biopsy or FNAC, or sometimes an excision biopsy. And once the histopathology comes as tuberculous, you treat the tuberculous with the anti-tuberculous treatment, and if the abscess is persisting, we may have to drain the abscess. And there are also the non-tubercular mycobacterium, which are medically amenable to treatment. Then you come to another condition which is called stenomastoid tumor, that is the muscular tumor, which is present in the middle of the sternocleidomastoid muscle. It is usually because of the hematoma during some kind of an injury to into this region, and forms a hematoma, and there is a fibrous tissue that is formed in the sternocleidomastoid muscle, and so there is a contraction of the sternocleidomastoid muscle, and so the patient usually complains of the torticollis, or there is a bent, and there is a fibrotic thing present in the in sternocleidomastoid, and so the torticollis is the condition where the face turned to the opposite side, head fixed on shoulder on the same side, asymmetry of the head and face is seen. So that is the feature that is seen in a sternocleidomastoid muscle mastoid swelling. The treatment is usually conservative. You may have to resect sometimes the attachment, inferior attachment of the sternocleidomastoid, so that the neck can be easily extended. Now, as we said, the skin is the one which consists of these sebaceous glands, and the sebaceous glands are the ones which can get infected when the punctum, that is the opening into the skin, is closed, and so it forms a sebaceous cyst, and the commonest complication of sebaceous cyst is a abscess, and it gives rise to a small sinus. This is what the sebaceous cyst is, and the treatment is excision. And lastly we come to the subcutaneously you have the fatty tissue which is present, and a tumor of the fatty tissue is called lipoma, which presents as a smooth swelling in the neck, and in the elderly it is in the nape of the neck. And this kind of a swelling which is present in the nape of the neck is likely the chances of transformation of this lipoma into malignancies. So the treatment is usually the excision. The cervical rib, there is a swelling in the supraclavicular region, and the patient have paresthesia, sometimes numbness in the limbs, and so the test that is done is the Adson's test, which is positive, and radiologically you see the X-ray of the cervical rib. If it is causing symptoms, excision of this rib and release the blood vessel and the nerves. Then you have the lymphomas, which are very common in children, and these are usually situated in the entire part of the neck. Then you have the parapharyngeal tumors, which will be discussed later, and the metastatic lymph nodes, particularly in the neck region, because the primary is somewhere deep inside. It may be in the oral cavity, nasopharynx, it may be in the maxillary sinuses, the hypopharynx, the thyroid, the lungs. So the various, they give rise to secondary metastatic lymph nodes in the neck. So you have to make a diagnosis with FNAC, diagnose the primary, and treat the primary accordingly. Then with that we come to the end of the neck masses, how the neck is divided into anterior and posterior triangles, and the various swellings that are present in the midline, how do you make a diagnosis of these, and the treatment, and then the lateral neck masses, how they present and the treatment. Go through these entire pictures once again, and if you have any doubts, you come back with those doubts. Thank you. Next, we'll have more patients. Eject చేసి తెలుసా నాకు
కంప్యూటర్ అదంతా ఇక్కడ ముందు క్లోజ్ చేయాలి అదాగా వీలుగా కదా మెథడ్ క్లోజ్ చేయి క్లోజ్ అయింది కదా ఇది అది ఉండదు ఇంకో కంప్యూటర్ ఇక్కడ కొట్టు కంప్యూటర్ తీసుకో మై కంప్యూటర్ పోయింది పోయింది పైన లేదా కంప్యూటర్ మై కంప్యూటర్ నేను చేస్తాను నేను నేనా I had not also.
చేసుకో.
Okay, bye. So in continuation of last classes, today I will deal with the infections in HIV. Infection means usually we expect to say opportunistic infections. Opportunistic infection. So if you remember the definition of AIDS, AIDS equal to HIV plus opportunistic infection, sometimes malignancy also. So under the immunodeficiency, the person is liable for getting all the infections, maybe bacterial, viral, fungal, parasitic, protozoal infections. Very difficult to cover. It's a very huge topic. Almost every topic it takes in minimum class. Suppose if I take fungal infections in HIV, so I have to cover superficial fungal infections, intermediate fungal infections, deep fungal infections. So under that prototype, actually, so even if I take prototype like cryptococcal infection also, it takes full 1 hour. So instead of that, I decided to speak only the common opportunistic infections that are present in the HIV patients. What are these opportunistic infections? These organisms are already present in our body. They live as commensals. So whenever the opportunity comes, that is opportunity. What is the opportunity? Is providing the body is providing immunodeficiency. So there is proliferation of these microorganisms that are already present in the body, or activation of the latent infections like tuberculosis. TB bacillus is already there. Since India is endemic for tuberculosis, it gets reactivated under the influence of immunodeficiency. So as I told, fungal infections, there are various fungal infections, then we have got bacterial infections, start from the superficial folliculitis, deep folliculitis, abscess, then cellulitis, erysipelas, all these things are bacterial fungal infection, and some pneumonias. Not only superficial, we have to think about the deep infections like meningitis or lower respiratory tract infections. Then parasitic infections like very exaggerated presentations like scabies or pediculosis. Similarly, protozoal infections. Usually we get Cryptosporidium, Microsporidium, Isospirabelli. These are the organisms, they are all protozoal organisms responsible for persistent diarrhea. They become one of the AIDS-defining illness with these organisms. So simple diarrhea due to E. coli or Salmonella, so that doesn't make much difference because they can be easily treated. But these opportunistic protozoal infections very difficult to treat, very difficult to diagnose. So sometimes we lose the patient with simple diarrhea, and it's very intractable diarrhea, persistent diarrhea. So it's a real headache for the patient as well as the treating doctor. They don't get cured like other diarrheas. So in India, the most common diarrheal organism is Isospirabelli. So usually we treat with trimethoxam, sulfamethoxam. This is a treatment of choice for all these protozoal infections. Then for parasitic infection, bacterial and viral infection. Say any viral infection that is present, usually the herpes group of viruses. So they present in HIV patients under immunodeficiency in exaggerated way, difficult to treat, and even if you start treatment also for simple herpes also, it would take longer periods of time, months together to treat it. Unless the immune deficiency is addressed, very difficult to treat any particular infection. So simultaneously we should give ART drugs. Unless ART drugs are provided, it is very difficult to suppress the opportunistic infections. So today we will talk the most important opportunistic infections are PCP, one pneumocystis carinii pneumonia, Nowadays we say pneumocystis cerevisiae pneumonia, and another is tuberculosis. So these are already told. So whenever there is immunodeficiency or the CD4 cells falls below 200, we start getting opportunistic infections. Usually these opportunistic infections will start when the CD4 count falls below normal. The normal levels are CD4 normal levels in 500 to 200. So when it starts falling below 500, in the beginning you get superficial fungal infections, then some superficial bacterial infections. But when it falls below 200, we start getting specific age-defining illnesses. So below 200 we get PCP pneumonia, and below 100 we get cryptococcosis, cryptococcal meningitis or cryptococcal dermatitis. When it falls below 50, then very difficult to save these patients, such patients, and they are likely to get all cytomegalovirus infections, cytomegalovirus mainly the retinitis. Then we get MAC infections, Mycobacterium avium complex intracellular. So these organisms again very difficult to treat, unlike tuberculosis. But remember, tuberculosis, since it is an endemic disease in our country, this can appear at any time in the CD4 count. Irrespective of fall in the CD4 count, TB can occur at any time. So this is all what I told just now. Various presentations in according to the level of the CD4 count. So the prototype for bacterial infections is tuberculosis. So what is the speciality about this tuberculosis in HIV infection is atypical presentation you can expect. Atypical presentation means usually the upper lobes of the lungs are involved in tuberculosis. But here you will not see the involvement of upper lobes. So instead you see involvement of the lower lobes. And you may see some infiltrations, diffuse infiltrations, nodular along the branchioles you may find. So sometimes you can see extra pulmonary manifestations. The most common type is pleural effusion. So pleural effusion comes under extra pulmonary manifestations, or they are present with lymphadenopathy, TB lymphadenitis, sometimes TB hepatosplenomegaly, or retroperitoneal lymphadenitis, or TB encephalitis, TB meningitis, so on and so forth. So extrapulmonary tuberculosis is very common in HIV patients, but when lungs are involved, atypical presentation will be there and very difficult to treat for the simple reason. So we like to combine with ART also. So nowadays the dictum is you start ART as early as possible so that the further development of opportunistic infections can be stopped. So that is the reason once a TB treatment is given, patient is stabilized, then you can start ART. Otherwise, if you start ART earlier than anti-TB treatment, they will go into IRIS. What is IRIS? Immune reconstitution inflammatory syndrome. So IRIS is such a very worst thing, sometimes we lose the patient. So that is the importance of treating opportunistic infection first, then followed by the HIV infection. So HIV treatment, we are all very eager to start the as and as treatment, but always exclude the opportunistic infections or latent infections. Must treat them because HIV is not emergency. HIV will wait for its treatment. Nothing is going to happen because of the long chronicity of the infection. So first stabilize the patient by addressing the opportunistic infection, then start treatment. Especially TB treatment, minimum 2 weeks you should give anti-tuberculosis treatment. Minimum 2 weeks. I personally prefer giving 2 months of treatment. The intensive phase, first you treat it. Once the patient gets stabilized, then you will go for 2-drug regimen. And thereby you are reducing pill burden also. Otherwise, TB treatment So a lot of side effects will be there, especially the gastritis or severe nausea, vomiting. So already TB treatment, especially the pyrazinamide, is associated with a lot of GI symptoms. So that is the reason first we will cut short the 4 drugs to 2 drugs after the completion of 2 months of treatment. Then once patient is stabilized, we can start that AKT2 2-drug regimen continued that rebounds in INH. Along with that, anti-TB treatment can be, anti-retroviral therapy can be given safely. So whenever you diagnose HIV, always rule out TB because they coexist most of the time. In 50% of the cases, they are associated with each other. Suppose TB you are diagnosed, rule out HIV. Invariably screen for HIV. If you are diagnosed HIV, thoroughly check for the presence of TB, pulmonary TB or extrapulmonary TB by doing all molecular biological methods for diagnosis. So here the clinical features will be variable since it's not related with exactly CD4 count. So it may be sometimes 400 or sometimes even 150 also. But patients usually present with all typical, if it is pulmonary tuberculosis, they will have productive cough, fever, dyspnea exertion and weight loss, night sweats. So these are the classical symptoms in the TB. And chest X-ray will tell you the cavities, mainly the lower lobes, not upper lobes. Upper lobes usually in the normal patients, normal non-HIV patients you notice. So your chest X-ray diffuse or lower lobe bilateral reticulonodular infiltrates consistent with the miliary spread, and there will be effusions or adenopathy, hilar or mediastinum, and maybe the involvement of the one lymphadenopathy or sometimes brain and its meninges, then retroperitoneum, GI tract. So diagnose AFB is very important. You test for sputum for 2 consecutive days. Early morning specimen is ideal. So same Gill-Nielsen stain we do after concentrating the sputum. Then stain with Gill-Nielsen stain, you will notice gram-positive organisms, pink staining organisms, just like leprobacillus. There is no difference in leprobacillus and TB bacillus. They are bacilli. Even if the sputum is negative also, it doesn't mean that you have excluded TB. So AFB will not be always give you a positive result. Only micromolecular level diagnosis is 100%. But just sputum examination, if it is negative, but if it is positive, what does it mean? The patient should be treated separately, isolated. It's an open case. Even if the pleural effusion also is considered as an open case, it should be given meticulously for at least 2 months with 4 drugs. Then only patient should actually move in the wards. Otherwise, it should confine to the room, separate room, and be treated. Sometimes the drugs, if you send him away, since they are associated with severe nausea, vomiting, they stop taking the drugs. We heard that people are actually afraid to take the drugs because of nausea, vomiting, and just throw them away and tell the family member that they have consumed. But in fact, it doesn't take, and that is the reason they are persistently positive for tuberculosis. We take a chest X-ray, the typical findings may be there, with infiltrations or abscess or pleural effusion, and sometimes there is a pneumonic patch also may be there, and of course lymphadenopathy, both hilar and intrathoracic adenopathy, pleural effusion. All these things may be noticed in the X-ray. Sometimes you see miliary tuberculosis, especially we see the miliary tuberculosis in children. So 4% of the cases they may present with miliary tuberculosis. Mantoux test is not reliable in HIV patients because already patient is under immunodeficiency. It becomes very easy to show positive. So I will don't give much actually importance to the Mantoux test, PPD. Purified protein derivative we use, and the induration is more than 5 mm, we consider it as a positive. So molecular technology, that is Roche Amplicar PCR is used, and we have got IGRA also. One more is quantiferon gold. It's actually nothing but IGRA only. Quantiferon gold is a trade name, trademark for that test. So sometimes the sputum also can be searched for the organisms after bronchoalveolar lavage. Otherwise you can take branchial biopsy also, with fine needle aspiration of the lymph nodes also. They will show the vesicles. The gold standard of diagnosis of TB is culture. It's time consuming and very difficult to reach the final diagnosis immediately. And this interferon, that is IGRA, interferon gamma rapid assay, that is called IGRA. It is also difficult to interpret, but it gives a reliable index, reliable report. If it is positive, you should be very considerate in starting the treatment. So treatment is just like any non-HIV patients. We give multi-drug regimen, that is 4-drug regimen. XGR is for resistant tuberculosis. XGR for resistant tuberculosis. But usually we give MDR only. 4-drug regimen we use. In the initial 2 months it's called intensive phase. We give 4 drugs, followed by once the patient becomes stabilized, you can just continue with the 2 drugs, that is rifampicin, INH. And during that time you can start this ART also, which are compatible with rifampicin, because rifampicin is a drug you cannot afford to lose it because it's a bactericidal drug. The patient becomes non-infectious within 1 month of the starting rifampicin. It's bactericidal drug. So always keep it in your mind, iris before you start. If you start late ART, the patient go into iris very easily. Suppose CD4 count is low, viral load is high, and you start treating with ART, they will go into iris. So that is the reason you should start ATT as early as possible after confirming with a test like IGRA, interferon gamma release assay. The total duration of treatment is 9 months here. Usually we give 2 months intensive phase and 4 months continuous phase. But in since HIV patient we give for HRZDE for 2 months, that is isoniazid, rifampicin, pyrazinamide, ethambutol. And again we continue only with the rifampicin and isoniazid. 2 drugs are enough. I put ethambutol also, not really required. So dose please try to remember, very important, very easy to remember. So INH, IREP, remember IREP. So isoniazid 5 mg, rifampicin 10 mg per kg body weight, ethambutol 15 mg, pyrazinamide 25 mg, very easy to, everything 5 increase, in all milligrams per kg body weight for 24 hours. So it can be given in divided doses or at a time. Most of the time this INH and rifampicin are given in single dose. Only pyrazinamide, since it is associated with gastrointestinal upsets, so we give in 2 divided doses, equal doses. And prophylaxis also, suppose if the household members are exposed, to the open case of tuberculosis, so then you should consider giving isoniazid prophylaxis for the rest of the family members. So these are few other guidelines and the dosage schedule. And it's all for resistant TB. So resistant TB usually they are supposed to refer to the TB center, state TB center. Both XDR TB and XDR. So these things they require some additional drugs which are expensive. Our patients also they cannot tolerate. But once it is expensive and the duration of treatment is long, so there is every chance they will become defaulters. They don't use continuously. So the second line drugs are kanamycin, amikacin, capreomycin, streptomycin, ofloxacins, ethionamide, prothionamide, cyclosaline. They are associated with a lot of toxicities. Astazone, usually when we say resistance, we are resistant to rifampicin and INH. These are the 2 important drugs. Other drugs nobody tests and they consider it as other only just accompanying drugs, multi-drugs. But most important are isoniazid and rifampicin. When we say it is MDR, multi-drug resistance means it is resistant to rifampicin and isoniazid, not the other drugs. Other drugs are actually, you don't have any test to say whether they are resistant to other drugs or not. And MDR, multi-drug resistant, that means 2 drugs are resistant. Another is XDR, that means extremely drug resistant. So these 2 types of drugs, they should be, and TDR, one other is now the new terminal is come, totally drug resistant, TDR. So these 3 types of patients should be handled by only the state TB control. There they do these resistance tests, as well as at the same time they will provide the second line drugs, third line drugs free of cost. Outside their expensive cost in thousands of rupees are required for every month. So next important condition we go for is pneumocystis jirovecii, pneumonia, EJP. So this is again a AIDS defining illness. So there is a lot of change after the advent of ART and awareness among the doctors how to handle this case, how to treat it. Because previously when there were no proper guidelines, we used to lose many patients because they were going into iris. If you give simple drug, sulfamethoxazole, trimethoprim sulfamethoxazole, patient is unlikely to go into iris with pneumocystis jirovecii. Very cheap, inexpensive drug, Bactrim DS or Cetron DS. So if you give for 21 days, you can start with ART. So most of the opportunistic infections can be treated with single drug. This is Cetron or Bactrim DS. So this usually presents with fever, chills, lot of sweating in the scalp and breathlessness. There may not be cough, or if cough is there, only dry cough. There is no sputum. So CD4 count invariably less than 200 cells per microliter of blood. So in this scenario, little about this. It's a protozoal. Previously we used to think it is a fungal infection, pneumocystis carinii pneumonia. So this fungus infection, because structurally there was similarity to fungi, but when functionally it was not responding to any antifungal agent. So this is responding to only antiprotozoal drugs. So now micro analysis of this organism will tell us that this belongs to the protozoal agent. And this is the symptomatology, and they characteristically feel a constriction in the chest when they are breathing. So there is difficulty in the breathing. And it runs a indolent course, and respiratory rate, there is a tachypnea, there will be rals, bronchi in the auscultation, and there is oxygen saturation will fall down. So this pulse oximeter is the right thing to monitor, now just like we are monitoring COVID infection. When it falls below 93 saturation, you should be actually become alert, admit them the patient and start oxygen mask. If they respond, and start with antiprotozoal treatment, Bactrim DS and fluids. If the patient becomes alright, invariably becomes alright, but if he deteriorates due to iris or an oxygen saturation falls 70%, very important. So it falls below 70%, we should be very careful that we may lose the patient. So here they may require a tracheostomy or more oxygen pressure is required. Even at this level, they may require a cortisone, IV corticosteroid is indicated when the oxygen saturation falls below 70. So previously, pentamidine was the drug of choice. It's an inhaler. Aerosolized pentamidine was the drug of choice in 1981-82 when the first time HIV was diagnosed. So other organs are involved are lymph nodes, hepatosplenomegaly, kidney, pancreas, pericardium, heart, thyroid, adrenal, but most important organ is in lungs. So diagnosed by chest X-ray. In chest X-ray, in the initial stage, it is normal most of the time. Sometimes you may see snowstorm appearance or sandstorm appearance, snowstorm or sandstorm appearance in the lung fields. So that is the scenario in the beginning, followed by interstitial infiltrate and perihilar lymphadenopathy. So HRCT is the best way of diagnosing, picking up the infection very early. So whenever there is infiltration or snowstorm appearance, the pneumonitis, light pneumonitis, so HRCT is the diagnosis of choice. Even for COVID also, before the hematological findings will tell you that he has got COVID with lung infiltration. The HRCT will tell us that patient is in the advanced stage of the infection. That is the reason we start remedies. In such cases, as early as possible, we notice the infiltration of ground glass appearance in the peripheries. If HRCT is negative, you can exclude actually PCP admission, which require oxygenation and monitoring pulse oximeter. So other laboratory findings, arterial blood gases, very important. There is actually saturation will be, oxygen saturation will be reduced, going into hypoxia, and there is increased alveolar gradient. So this DLCO, diffuse capacity for carbon monoxide, it's a good screening test. If it DLCO is normal, PCP diagnosis is unlikely. So other parameters can depend on lactic dehydrogenase. If these levels are increased, that means patient is going into metabolic acidosis. Similarly, CD4 count is falling below 200. That confirms that the patient may be having a immunodeficiency disorder like PCP. So definitely diagnose demonstration of the organism by ball, bronchoalveolar lavage, otherwise HRCT, or you have to stain with Giemsa stain or methionine silver stains, toluidine blue stain of the ball or bronchoalveolar lavage. PCR also will detect the DNA sequences of pneumocystis carinii. So prophylaxis with aerosolized pentamidine lowers diagnostic sensitivity of the sputum induction. So yield of sputum induction is 64% when compared to 92% in patient not receiving pentamidine prophylaxis. Antibody staining techniques may enhance the sensitivity of the test to the tune of 94% to 100%. And this ball can be performed with fiber optic bronchoscopy. Now it's very simple to diagnose. Most of the time we go by clinical diagnosis. Just tachypnea, tachycardia, breathlessness, fever, high-grade fever with night sweats. Then you can suspect HIV patient with CD4 count round about 200. Blindly you can diagnose PCP and confirm with chest X-ray or HRCT. Then management very simple, cheapest track, trimethoprim, sulfamethyl, methoxyl, and sometimes you can, if that is not acting, not available, you can start giving pentamidine, lateral pentamidine. But pentamidine is less effective when compared to TMPS index. So whenever a patient is sensitive to sulfa drug, because bacterium DS are after all it's a sulfa drug, so they may be getting hypersensitive reaction, especially TEN, SJS, Stevens-Johnson syndrome, and toxic epidermal necrosis. So in such cases, you can give dapsone or pyrimethamine. There are alternative drugs, or clindamycin, atavapone. So luckily it gives very good response with trimethoprim sulfamethyl. Treatment should be continued for minimum period of 3 weeks and followed by once daily of TMPSNX till the CD4 count goes above 200. So the threat of getting PCP is there as long as CD4 is at 200 level. So these are the side effects of TMPSNX. So pentamidine is alternative drug. Okay, I think we have finished this here. So I is the thing that we should keep it in your mind. So these MAC infections, as I told, when the CD4 count falls below 50, you should think about MAC, Mycobacterium complex, and we have got 2 organisms in this Mycobacterium complex. Complex means that means we got multiple organisms. One is Mycobacterium avium, another is intracellular. So these 2 organisms we have, they are present throughout the globe, and they produce similar symptoms like TB, and the portal of entry is respiratory and GI tract. So this makes appearance when CD4 count is less than 50, and there is no specific management except we have to give tuberculous drugs like here this anti-protein anti-tuberculous drugs they don't have. So here we depend on the other drugs like erythromycin or azithromycin. So these are the wonderful drugs, cheap and best. Otherwise clarithromycin. Clarithromycin is expensive when compared to azithromycin. So other bacterial infections very easy to treat with criminal group of drugs. Okay, I will end this here. Thank you.
తప్పకుండా బండి అయిపోయిందా పైపు తీసుకోవా రెండు కిలోలు వచ్చిందా నేను అట్ట కూడా ఉపాధి రెండుగా ఒక్కడు రానున్నా కూడా అది రెండుగా వస్తుంది సార్ హలో ఏమి చూపిస్తావు లోపల ఏం పని చేస్తావు రెగ్యులా ఇప్పుడు ఒక్కలేదు కాదు రెండు సీట్లు రిడక్షన్ ఉందా రిడక్షన్ చెప్తా రిడక్షన్ రీడ్ చేస్తాను అదే సరే ఇవ్వండి మీరు ఫస్ట్ రిడక్స్ అయిన తర్వాత పేమెంట్ చేసుకోవాలి రిడక్స్ వేసుకోవాలని చెప్తాను సరే ముందు ఏమైనా చూస్తే రియాక్షన్ అయినప్పుడు వాళ్ళు ఏ కొందరు తాగినట్టు నిద్దాలని చేస్తారు, ఏదో ఒకటి ఉడికి రాదు, అంతా చెక్ వచ్చింది కదా, ఏదో ఒకటి ఉడికి ఉత్తేమైతే అంతేనా? అది పైసలు పడుతుంది, 20,000 బిజీ శ్రీకాంత్ 20,000 అంటే పోయింది. అదే అది రిడాక్టర్ ఏమైతే పైపోతాం ఏం కాదు కదా. చెప్పాలి నా ఉద్దేశం అది మాకు తెలిసినాక నా ముందే మనకి